Hello, and welcome to the Alabama Public Health Training Network. I'm William Kennedy, State Social Work Director at the Alabama Department of Public Health. Thank you for joining us today for our program, Ethics in a Post-COVID World, New Challenges and Familiar Solutions, Part 1. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handout, sign-in sheets, and evaluations are available online. You'll need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years for nurses and social workers, expiring on June 15, 2024. If you're watching this program on demand and want to receive a social work CE certificate, you'll need to complete the social work test and send it in, along with your sign-in sheet and your evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it's considered non-classroom hours. Before we get started, I'd like to introduce our presenter today. Jim Sacco is a consultant to the Alabama Department of Public Health. I know you have a lot of information, Jim, to cover, so let's go ahead and get started. It's great to see you, old friend, well known to us.
Thank you. Thank you, Bill. It's good to be back. Welcome, everybody. Thank you all for being here in the room. My name is Jim Sacco. I'm a social worker. Based, I'll say that proudly, based in Asheville, North Carolina. I have, a long time, 35 years of social work career, mostly a mixed bag of clinical services until almost 20 years ago. I met some people who said, we'd like to teach you how to be a trainer. So kind of a weird fork in the road where I made my living doing legit social work, and now I'm mostly in the basement of a county health department pretty much anywhere in the southeastern United States. I always say I know every Waffle House from here to there and back. So anyway, it's good to be here. I was excited about the topic. I know ethics is not the funnest thing. Let's keep it real, shall we? But I thought, what's a way to make it interesting, and what's a way to ground us as nurses and social workers, sort of in where we've been. And so I just sort of thought it made sense as we were designing the program to think about sort of where we've been and just kind of catch our breath. I debated the term post-COVID world. Is it post? Is it kind of? Is it peri-COVID? What I thought is, it certainly seems like we are through the most acute phase of COVID, and I'm anticipating there'll be waves, and I don't know what normal will look like. But I use that language to just kind of say, okay, we've been through a couple extraordinary years as nurses, as social workers, as public health people. And let's catch our breath and kind of think about how our ethics have grounded us through COVID, and how our ethics help us move forward. So it's a review, as Bill suggested in the title. I want to talk about where we've been. The other thing, full disclosure, I'll give you the preview for the whole day, the whole couple series. The NASW 2021 did an amendment to the existing NASW Code of Ethics. Two things they focused on I thought was interesting. One, they enhanced and beefed up the language about professional self-care as an important requirement, and they expanded and reiterated the importance of cultural competence and becoming a better social worker. So as I sort of prepared, I wanted to highlight those two changes, talk a bit about sort of where we've been, as I said, and then talk a little bit about what hasn't changed. The good news is there's a lot that hasn't changed. So there's our goal for the training. We're going to sort of talk about what good ethics do to ground us in public health practice. And there was something about reviewing, going back and Googling what is ethics, and going back and Googling what are nursing ethics. There was something that really filled me up, just sort of proud to be a public health person as I looked at what our ethics tell us we ought to be. And I hope for everybody here and everybody watching on the video, it's a chance to kind of pause and reflect on why we do the work we do. It's not just for the extraordinary salaries the Department of Public Health pays us, but it is from a place of wanting to make a difference, and ethics are part of how we get there. So those are objectives, and these are kind of the objectives for both days. We're just going to talk about challenges, we're going to talk about the updates, and again, talk about what we've learned in the age of COVID, and what challenges, I guess I'll put that out as I was thinking about what challenges have arisen that we weren't expecting or that we didn't know about, and what have those solutions been. So I want to do just a little bit about our foundation. There's what the National Association of Social Workers tells us ought to guide us, and this is the outline for what the NASW Code of Ethics talk about. They say first that we are responsible to clients, and I'm delighted to be reminded that that is the first thing they say. Our ethics are about what our clients' needs are, about the needs of the individuals and families and communities that we serve. I think it's also really important that we, as social workers in particular, think not just about the individual clients, but in case you missed the first day of social work school, I'm talking to everybody over here, what they said is the person in the environment. And so our client certainly is the individual in front of us, but is also families. And in public health, I think our responsibility also extends beyond that individual to the community in which they live. But responsibility to colleagues was right there, and sort of thinking about, how we be a part of a collaborative solution in public health. And I again, as I stumbled back to this foundation, I thought I really like that. I think, as I think about where we've been through COVID, I'm not sure we could have done it without each other. And I think there are hundreds of examples of people whose teammates pulled them through, and people who helped us navigate the unknown, and people who helped us grieve those who've been lost, and helped us through those scary times of people getting sick, and those decisions about to get vaccinated and what safety looks like, and so again, the reminder that our code of ethics is about not just me as an individual, but about me working in partnership with the people with whom I work. Responsibility in the settings in which we work, and in this case what that means is we do have a responsibility to the county health department, if we're there, to regional offices, to the state of Alabama Department of Public Health, but that our responsibility extends to sort of how we behave in our work settings, to how we promote our work setting. It's the reason why when we find people straying, in their social media or in their venting here or there, that the people for whom we work say, hey, you have a responsibility to not act crazy in public because you are the public health. Responsibility as professionals, obviously, it's about the codes of professional conduct. It's about conveying respect about ourselves. It's also about conveying respect for the entire organization. That we talk about professionalism. That doesn't just reflect on me, but it reflects on everybody that works under that roof with me. And then finally, again, as social workers, responsibility to the society. So there's a sort of graphic depiction from a slide deck within NASW. All these are taken straight from the NASW website. Competence, obviously, service to others, obviously. What's also important as we do our work today and start to think about this reiteration in the 2021 amendment to the NASW Code of Ethics about the importance of cultural competence in our practice, and the idea that laid out in our foundation, this goes back many iterations of the Code of Ethics, is the idea of social justice. And I think what's important is that that idea of social justice, there's a way of sort of dismissing cultural competence and the ability to respond to injustice that exists as sort of being politically correct or sort of poo-pooing. The reality is, for social workers, and you'll see in just a minute for nurses, there's a way in which addressing the macro issues, that's the way they said it in school, didn't they, Bill? Macro issues, is foundationally part of who we are ethically. So this is not just people being woke, I'll use the term people use to dismiss the idea of social justice. It is about a foundational belief that we ought to live in a just and fair society. And as social workers, we advocate for that. As nurses, we advocate for that. So dignity of the person, importance of relationship, and integrity, which again brings us right back to the idea of what are our values, that people who are acting with integrity are people who know their professional values and act on that. So Nursing Code of Ethics, this is a 17 version from ANA, and look at the similarities. Look at the similarities. Patient right to self-determination. Nurses talking about patient right to self-determination. Doggone it, I thought we were the only ones who I thought we had the market on that bill. No. Everybody's saying grown people got a right to run their own lives, as we say down in South Alabama. Grown people. Beneficence, the kindness, the idea of justice right there in the 2017 version. Nurses also saying that fairness and equity ought to be part of our conversation. Non-maleficence means do no harm, and that's the way you pronounce it. I promise I looked it up on Merriam-Webster. I know, malfeasance, maleficence, I had to look it up, maleficence, and the other is acceptable as well, and then the importance of confidentiality. So I'm doing this quickly just because most of us know this. We learned it in nursing school, we learned it in social work school, but as we move into what are the challenges today, I think it's super important to go back to where we've been, and for me, again, it's to go back with pride and to kind of recognize that if we're acting on the best part of our ethical principles as nurses and social workers, we're right in line with the values of public health and where I think we ought to be. So provisions of nursing compassion, that's obviously their commitment to the patient. Again, what's interesting, they spell out family, individual, community. I was really, I'll be honest, I wasn't expecting the nursing ethics to go as far, to be as close to social work ethics as they are. But what strikes me is there's a really smart, really forward-thinking group of nurses that have put forward for the profession what nurses ought to do. And again, it aligns with those macro issues that we as social workers looked at, promoting, advocating rights, health, safety of patients, responsibility for practice, making decisions, duty to self. Interesting, again, as we talk about those enhancements to the NASW code, that in the Nursing Code of Ethics, right there, foundationally, you got to take care of yourself. Put on your own mask first, Kelly, I always say. Isn't that what they say on the airplane? Put on your own mask first. And I think it's important, and I was glad to see it brought forward specifically in the Code of Ethics, because I think we're all terrible at it. There's every nurse and social worker I know could be better at it. We're many of us saving the world and taking care of everybody else. And so that reminder, and especially as you'll see when I get there, especially in this post-COVID emotional fallout that I think we're all in. Nurses working at environment in their work setting and making using their ethics in the workplace to create again, very similar to what the responsibilities of social workers, and advancing the profession, the last part of the provisions of nursing, collaboration and responsibility to others in the profession, and articulating nursing values. So again, really a lovely statement of who we are. And again, I wanted to do this, again, for many of us, it's not new, but I thought it was important as we sort of talk about where we've been, where we're going, that there's a whole lot that hasn't changed, that those have been in place. The NASW code is 50 years old with some refinements here and there, but I know the original code I saw goes back 50 years, and the A&O code certainly goes back at least that far. So what happens when people violate those? This is a 2014 study, but it was the most recent thing I could find, but I looked at it, I thought, yeah, that's probably about what happens in order, the most common violations for social workers. This is exclusively to social work practice. First is boundary violations, and the most common of those, sexual relationships. I am disappointed and not surprised. How about you, Kim? Disappointed? She said, my old social workers just shrug and go, yep. My veterans, sorry, Bill and Kim, my veterans, unfortunately. And you know, we are humans, and we are humans who are in contact and make relationships with people, and for people who are prone to ethical transgression. It's not surprising that that's most common boundary of sexual relationships. Never ever okay. Let me say that has never changed. That will never change. Never ever okay. And I got to say, I'm someone who says never ever. There's some debate among clinical social workers, or, well, it was 5 years ago. Well, this. I say never. I say if that person has ever been a client in your practice, nurses, if you've ever provided direct service, to me, it's never okay. And again, the code of ethics in North Carolina, where I practice, is a little fuzzier, and there are people that want to debate that. I just think for patient safety in the world we live in, and I just think never ever. I think if you've had a profession, you can never have a personal relationship. I take a hard line, and again, that speaks to client safety. And again, I just think about all the sexual abuse that we know. We know 1 in 4 women. We know 1 in 6 men. All the other stuff. I just think, what, given and people that come in most vulnerable, who have a history of trauma or adverse child experiences, I take a hard line. I say never okay. So other violations, bad practice, just not competent. Not surprising. We can all think of those 1 or 2 people in our class we thought, and they're going to go out and practice nursing. Don't name their name, Kelly. We'll all go to prison. But we all scratch our head and say, was social work a right choice for her? I said to myself, I wish her well, but I saw that and I thought, not surprising that a couple of them got written up for sleeping through class or just not taking in anything they should have learned at school. Bad records, dishonesty, confidentiality. Billing, obviously we've got some people that playing fast and funny with the money. That's human nature. And again, conflicts of interest. And again, I always get nervous when, we all know that person who's promoting their own side gig. They work till 4 at ADPH, but they've got a side gig and they're handing out cards. You just think, well, really, do you want to be handing out your other gig while you're at work? Or anyway, conflicts of interest come up as common complaints. So I'm going to turn it to the people who are in the room. That's sort of what's historically happened. As you think about where we've been, what's been challenging about the last couple of years? Let's also all kind of reflect. I always say, let's fast forward back to March 2020 when the world changed forever, right? And think about that 2 years and 2 years and 5 months now. What's happened in nursing practice, in social work practice? What have you seen as ethical challenges that have arisen as a result of the COVID pandemic? Anything come to mind as a challenge?
I wrote one thing,
Please.
Jim. One thing that's kind of come to my attention lately has been the nurses that went to New York and other areas, travel nursed, and the things that they saw have brought that back and are really struggling, is what I'm being told by some of my nursing buddies, that PTSD is just real. Things that the bodies that were stacking up, and
it's unbelievable. The front line,
you can't unsee that, and so and they're really struggling with that now.
You bet. No, I mean, I think it's unprecedented, and certainly most nurses in nursing school, do they say prepare yourself for a global pandemic? Where you're going to see right. So clinical practice that involves that level of acuity. And Bill, let's bring it home. I remember being on the phone with Rhonda. She's saying we got no emergency beds in all of Montgomery. We got nothing in Birmingham. We're trying to find emergency beds. They're shut down here in Montgomery at various periods. But yeah, the level of patient acuity, the volume of patients. Larger hospitals that my buddy works for a large hospital in Atlanta. They had refrigerator trucks lined up out back because they just didn't know. Luckily, I don't think they used them, but it was so bad in the day. Right, you got refrigerator trucks for human beings because
you normally used during tornadoes and hurricanes. Our emergency preparedness stuff. We're now pulling out and using for a pandemic.
And so it's the level of acuity, it's the amount of illness, it's
Staff shortages.
personal safety, staff shortages, absolutely. Just not having enough people getting sick.
Yep.
You know, the other thing that happened, people got sick. I'm going to add the challenge of just being on the front line, having to say, no, you can't come see your grandma die. You know, when I think about what still breaks my heart, it's these scenes of grandchildren up against the window saying hi to Mima on the assisted, or worse yet, saying goodbye over FaceTime, because we just medically couldn't let people in. And so rationing PPE is another one. You know, we just didn't have, back in the day, we didn't have enough equipment for people. So who gets masks and whatever. Other challenges.
I think there's a divide among our colleagues about the choices that we make when it comes down to our personal safety and what we feel is best for us versus what other people think.
Yeah.
It's a personal choice to wear a mask.
Yeah.
Don't judge anyone else who doesn't wear a mask. Personal choice about vaccination.
Yeah.
But
Yeah.
you had a split with people who we've had families to fall out about COVID and
about what do you believe and who's
vaccinations and
vaccinated.
yes,
Is it real or not?
right,
We
exactly.
go way back. Is it real or is it made up?
Exactly.
Yeah. And I think right behind that, Kim, the unfortunate politicization of what COVID was. It's a public health problem. It's a health problem. But it became a political divide. Are you on this side or that side? And then within offices, within families, and with clients. I mean, the other challenge as we talk about the ethics is my code of ethics says a patient right to self-determination. Everything is, we're going to treat every patient equally is what I learned. And what about those patients that make different vaccine choices than I do? What about those patients that make different masking choices that I do? And then it gets into a really gray area of what our ethics tell us about continuing to provide services around those differences and potentially the personal risk we take. What else comes to mind as I say ethical challenges? Anything I've missed?
You know, I know our social workers in schools struggled. We work real close with our school system here in Alabama. Gave updates. Our nurses were working with the school nurses and others in the school system, and being able to make those choices. Families wanting to make choices for their children. But trying to keep people safe.
Yeah. And trying to teach kids on computer and close. And I think it's generally agreed that for safety reasons people needed to send kids home for a while, and that kids didn't learn much at all, and some backslid as a result of virtual learning and the stress on parents. And then teachers caught in this mix of who's vaccinated, who not. You know, again, kids were late to come to the vaccine party, so it wasn't even an option. So I know a lot of teachers who said, oh, it's great, they're opening up the schools with these 25 unvaccinated little vectors of infection, already giving them every cold, every flu, every whatever else, and now they're going, I got my mask on, and then trying to get kids to mask up. I feel for anybody working in schools.
Our DHR workers, are those that were going out and making home visits, those that, I mean, we know that abuse and neglect didn't just stop because COVID started, and so now those that are out there on the front line trying to protect people.
And I don't have good data, Bill, and I've looked on child abuse and neglect or domestic violence, but you can't tell me that locking people up in their house, too much liquor, that there wasn't a whole lot. There are anecdotal reports, but I've not found any hard data that said child abuse, domestic violence increased in 2020. But I see drinking rates that say 50% more alcohol consumption. And knowing the clients that I've worked with, I'm an old substance use guy. You can't tell me that Bubba drinking twice as much as he used to drink. There wasn't more violence in that house. I'm pretty sure of it. And and we'll talk about it, but people who had to stay on the front line. Again, this whole dilemma of who needs to keep coming to work and who can't, and who can do their job virtually, and the inequities in that. We'll talk about that in a minute because, I'll just give you a preview. Essential workers are disproportionately black and brown. And so what that's meant in terms of the inequity, particularly early on, is striking. And that's, as people committed to social justice, committed to fairness, we all kind of have to think about who stayed home and who didn't, who had the ability to decide, do I want to interact with people I don't know or don't I? So, yeah, you guys, those are a lot of things I thought about again. This shift to virtual practice, I think, is part of what I wanted to remind us of. So this starts the 2020 amendment, social workers' measures to care for themselves professionally and personally. That's the language in the introduction to this amendment. Act honestly in response to ethical practices as part of organizations. But I think what happened, this late 2020, it was ratified, I think in 2021, was the profession just kind of said, for all the reasons we've talked about in 25 more, it's been an unprecedented difficult time for people on the front line. And so let's reiterate in our code of ethics that social workers can't provide good service, can't do all the things we're supposed to do unless there's an ethical pillar that says the importance of professional self-care. This for those people watching on video. You've got on video conference. You've got the option to email questions in. Bill is tracking those. There's also the option to phone. And if you look at the website through which you registered, you can phone in, and we can do live call-in as well. So please, if you've got comments or addition, I realize that there's a disadvantage to being in your office watching this, but we'd love to converse with you. I'm happy to take questions or comments. Alabama Public Health Training Network questions is the way you send those. That's the email address to do that. So, like I said, I'm struck by, as I thought about where we've been, I think about shutting down. My birthday was March 13, 2020. And it seems like that weekend was the last normal weekend of life. That I don't know where you were when you, right? It was so crazy because I was like, did I really go out to a restaurant on the 12th and act like something was happening in New York and Seattle, and I'm gonna go out and have me a birthday supper? And that next week, I mean, it was unbelievable. So I can tell you exactly what happened because I went out the 13th and 14th. I did a business meeting in person, and it was already like a ghost town. It was already kind of weird on the 16th. And then the world shut down, brother, I tell you what. And everybody said, well, clients still need help. Schizophrenics still got to get their medication, Bill. Child abuse and neglect hasn't stopped. We need to do that. Medical needs haven't stopped. I think we postponed anything routine, brother. I had a surgery pending, and they said to me, we ain't dealing with your facelift or whatever I got. I'm not going to get in my business. But they said, no, we ain't fooling with that. We're triaging all this COVID we got here. But for everybody else, it's like, well, heck, how do we do that? And I'm struck by, if you think about 2019, how many of us, I know people that had never done a Zoom. Like, how does this work? Hadn't done a Zoom, hadn't done a Skype, hadn't done a whatever. And I just have to say that we as professional nurses, social work, other public health people, went from 0 to 90 in about 6 or 8 weeks, and it really was unprecedented. I think we can all be proud of what happened, and certainly people made mistakes. I mean, stories of people on their personal phone talking to a patient, no HIPAA, no nothing. They're on their phone at the McDonald's, and everybody's but we all did the best we could and rose to the occasion. And people that said, I don't know how a computer works, I don't know how a smartphone works. Well, buddy, you better learn. And we did. And the legal people and the administrative people got software and hardware ramped up. And so, just what happened, counseling, video conference, telehealth, unbelievable amount of telehealth. If I know so many clinics who shifted in a month, in 6 weeks, and said, get your smartphone out, we're going to do your visit. Again, because of the contagiousness of this thing, people were not saying, please come in our health department. They were saying, don't come in our health department. But things that needed to be seen, things that needed to be addressed. So, again, historically, computer tools, web-based communication, everybody on their smartphone doing various things, and just again, the fact that over the last 28 months, we went from, it was very unusual for me to meet somebody who said, oh yeah, I'm doing telehealth visits to do health care, to now, clinics I know where some have retained it, not just for COVID prevention. Again, some folks have said it's a better match for us, it's a better match for our patients. So let's talk about that, this crazy shift. What are the good and bad things? I want people in the room to kind of talk to me. From a client perspective, the good and bad things about this shift to virtual. Let's just kind of go around the circle. From a client perspective, good things about going to technology.
I think it made it easier for some of our clients.
You bet. Some who said, I ain't driving back to your clinic. I'm not. You think about Alabama. I wish everybody was a 5-minute bus ride or whatever else from a clinic. We got a lot of folks who have to drive for services. So yeah, suddenly I don't have to beg somebody for a ride to the clinic. I can just call my social worker, call my nurse, and everybody had a smartphone. So yeah, so ease for clients, flexibility, do it wherever I want it. Some clients are saying, I don't want to go back to driving, getting or having to argue to get a ride back to your darn health department. It's easier.
Some of our programs, we actually saw an increase.
You bet. Some people said, I'd rather do that. There's an anonymity. It's a little less vulnerable for some people doing that. Other good things from a client perspective?
There were a lot of connections lost during that time from isolation, and so the ability to still have that connection with the therapist.
That's super helpful. We forget how deep the isolation was for some people, and I still reflect on people that had been holed up for 6 months or a year, really cut off from people who lived alone. People in that isolation, yeah. And so, wow, my social worker, my nurse is there. I have access to somebody. And certainly, if you had any history of depression or if isolation was an issue. Bad things for clients. I think it did not work for some clients. I think there's some who just said, I want to see a person. And I know some people that had patients line up as soon as they said, we're doing live visits. There were a percent of patients who said, I want to give me the first appointment that day. That there was something about the technology that changed the connection for some people. And not everybody. And again, I think you're absolutely right. There's some people who found the flexibility and the ease of doing it an advantage. Some did not. So just need to acknowledge that. What else from a client perspective? Good things, bad things about the shift to virtual?
Go ahead,
Kim.
Trust.
Trust.
You don't trust that something can be missed if you do it on the phone or virtually.
Yeah. I know people, yeah. Can we trust we're picking up everything? Can we trust I rely so much on people's body language and on facial, and people make a twitch or they do whatever. I don't know what it means, but I might probe that. You don't have that on the phone or on the thing. And so yeah, I think the downside, you're kind of shifting us from the clinician perspective. I think you can make an argument that we lost some things as clinicians, as nurses. We lost the ability to do some physical exam, to see some things. I mean, you can hold your phone here or there, but I think the ability to do a physical exam for nurses and have a patient there in the room was at a price. And for social workers, sometimes we didn't get the full story, maybe.
You didn't necessarily know who else was in the room with that person.
Oh, my Lord, right? As it is, I think about people doing home visiting who have to say, no, Grandma, you got to get back in your room. We can't be talking about somebody's meth addiction while you're in here getting your Kool-Aid going back to your thing. And so, yeah, the compromise, again, the patient at the McDonald's, yeah, I'm on my psychiatric meds, blah, blah. You're like, going, no, we cannot be at McDonald's using their Wi-Fi, talking about your psychiatric meds. But yeah, and how we assured that, I mean, we could control it on our, once we got our systems up and we got HIPAA compliant too, we could assure on our end. But on the other, and let me just say, I can't stand anybody putting me on speakerphone ever. So there's that. Do not ever put me on no speaker. Am I right, Kelly? Do not put me on no speakerphone. But I have clients, I was on speakerphone, phone sitting there. Who's walking by? Who's hearing? Thinking we can't control it. And the bind we're in ethically is we're violated to protect privacy. And what if they are in a public place? What if they've got us up on a web tool in a place that's not secure, where they don't can't control who's there, people overhearing.
The other side of that would be if there's somebody in the room and they would disclose something to you, but they're not going to disclose it because the perpetrator potentially is in the room.
Yeah, absolutely, absolutely. So if I don't have privacy, it's the reason why SMS texting has real limitations. I've done a bit of work with domestic violence. They've got, if you're in a domestic violence agency, you've got all kind of code words and other stuff. You can't just say how's he, you can't expect someone who's under threat, because controlling the text is part of the disorder. It's part of how abusers operate. From an agency perspective, if you're running a health department, I'd have pulled my hair out, I'm telling you right now, with, am I going to be sued for HIPAA? Let's start there. Is any of this HIPAA compliant? Are we, the concern about privacy, how to get the technology up to speed, how to get technology that was HIPAA compliant, how to get everybody trained up in the tools. I'm not aware of, and our funders, all the insurance companies, Medicaid said, go ahead and bill us for virtual services. And I think there's a great deal of generosity on the side of funders and whatever else. But again, as administrators, as people leading, to kind of say, how on earth am I going to get, think about a busy health department. Think about, Jefferson County Health Department. How are you going to transition? Think about Mobile. Think about downtown. How are you going to transition that level of, that amount of service delivery in 4 weeks, 6 weeks to all virtual or mostly virtual? What can go? What can? It's been an incredible administrative challenge for people in public health leadership, I think, everywhere in the state. And they wanted to do the right thing, and sort of quality, the issues we've raised, quality of services, issues of privacy, issues of confidentiality. If I'm running a health department, my two biggest fears are a lawsuit and being on the front page of the newspaper. Bill, wouldn't you see? You've talked to a number. I don't want no lawsuit, and dear Lord, I don't want to be on no front of no newspaper having to defend something.
And to the funders side of the thing, we're seeing audits now 2 years later.
Yeah.
And so how well did we document? How well did we bill? What are they going to find? And so I know there's some concern there, you know, and certainly there's a lot more things been put in place with all the funding that flowed in. Yeah. Okay, now what did you do with it?
Yeah, absolutely. And I was in a telehealth arrangement with a provider, and they kept saying, well, the guidance is changing, and we're even appointment to appointment, they're saying, we're not sure if we'll be able to keep going virtual or not. And so private insurance companies, again, first year, we're just go on. We'll absolutely be happy to reimburse for a telehealth visit, but that changed, and yeah, the track record of who did what with those services. I mean, obviously there's an accountability, and yeah, if I was a major funder, I probably would do some look back and say that clinic billed X. Let me see the documentation about how services were rendered. And I think we all did our part, and I bet we didn't do it perfectly. I mean, I bet if I'm just picturing the people who are tasked with auditing us, the little beady-eyed bean counters they send out. Yes, I did send out to audit our charts. Some of those folks will find some things that aren't 100%. I reckon we were doing the best they can. And you just hope that goes there. So again, first thing, this hasn't changed. I'm not going to do a lot to these, but what's really important as we think about sort of this shift to a virtual world, about informed consent. What has fundamentally been part of nursing practice, of ethical social work practices, is someone's informed consent. And so again, as it relates to these telehealth, electronic, web-based, whatever else, the first element is who's going to have access to my clinical information? Where does this information go? Who has access to that? So as we are negotiating informed consent, you have to be able to say, here's who's going to be able to see what goes on. Second element, again, these are from the NASW code on using electronic media. Second thing is, what's the process, and do you have alternative for services? So in other words, ethically, for our profession, to say you can only do this or not is not appropriate. That we are challenged as social workers to say we're providing this, but to offer alternatives where those exist. And again, I'm thinking specifically about patients for whom doing services virtually is not clinically what their preference. And so being able to figure out whatever else is going on. And then, yeah, all these questions of how we're going to communicate and how I'll respond and what about misunderstanding. I'm going to raise my hand. I come off short and a little crabby in email, I've been told multiple times. And I'm just in a hurry. And I'm saying, girl, do that thing I told you to do, boom, whatever else. I'm just busy and send it off. And I've had more than one person say, wait, what's up with your attitude? And I'll be like, it was just a busy day. I was trying to, Kelly, you're smiling because you've been caught too, I reckon. It was 4:45. I wanted to get that out before the end of the day. And I was just like, here's the whatever without a lot of bells and whistles and how's your mom and him and hope you have fun at soccer practice. I was like, just do this thing. And so sort of ways in which technology, again, if you don't have the visual, if you're not here in the room, if I walk down the hall, I visited with you, say, well, Jim's just distracted and busy, that's who Jim is and whatever. Whereas if you read it in writing, there's ability to say, well, what's up with that? What's up with Mr. Krabby? Always, as part of informed consent, issues of confidentiality. We had to go back as we shifted to virtual service delivery and kind of say, here's not only who sees this and here's who has access to, but to explain that the law protects them. We had to pretty darn quickly get everybody HIPAA compliant. With us, what's astounding, and I'm smiling, Bill, because I think about how quickly we got HIPAA compliant. I wish it was because companies, I won't name the very large web-based providers of technology, we just wanted to do the right thing, but there was a real economic incentive. If a large web-based somebody, I'm thinking of several companies that were not HIPAA compliant when we started, and brother, they got HIPAA compliant in a minute because the way of moving to web service delivery meant, I look back, I had an earlier version of this talk, and there were all these weird kind of one-off, they were not things we were using anymore. Companies that were HIPAA compliant, I did early in 2020, or early in the pandemic, I did a thing like, here are the HIPAA compliant tools, and I thought, I never heard of any of these because the big boys said, "Oh, well, hold on, we're going to jump on that." So, but yeah, issues of confidentiality obviously have to be there, and these issues have not changed. Confidentiality is at the heart of what we nurses and social workers do. The exceptions down there always abuse, neglect, threat to self or others. That hadn't changed. Bill, I was in social work school. I think Eisenhower was president. It was self to other, harm to self or others. Or maybe it wasn't Eisenhower. It could have been somebody. But it was a long time ago, Kelly. I promise you, you were in middle school. Issues reinforcement about privacy and risks to privacy, and then ways that they can manage privacy. Back to this issue of where they are. And it's like, please, keep your password safe and don't share this form of communication. Don't be in a public place while we're doing it. All ways in which we try to work around and continue to try to work around the issue of privacy on the client side, so that we're coaching them, working with them. And this reminder just kind of says it's up to us to manage the clinical relationship. That ethically, again, go back to the nursing code, the importance of client services, patient services being the most important thing. We've got to monitor what's going on in terms of the therapeutic alliance. We need to monitor what it's doing to the communication, and we need to have a communication loop with consumers about how the technology is working and problem solving. And I know we've returned to in-service delivery, and so, just what can I do? I'm going to do is just shoot a quick text to somebody. Can I shoot a quick text? Well, hold on. Most texting is not on your personal phone. The answer is no. I'm going to just check in on FaceTime. Well, it's so easy. I got a phone by that certain big company. They got a phone. I'm going to just do a FaceTime. email homework? Can I email phone? Again, just some questions to get us thinking. Obviously, there are HIPAA compliant tools, but the question behind all of these is the tool, are we a HIPAA, are we an entity covered by HIPAA? If your check is signed by the Alabama Department of Health, the answer is absolutely yes. You must be HIPAA compliant. And then finding tools, texting tools, email tools. So again, are we a public, are we a PHI protected entity? The answer again for almost all of us, I assume everybody watching on the videos, yes, a covered entity. Provides treatment, payment, and operations in healthcare. We are covered entities, and so that means HIPAA has to guide everything we do as we're making choices about technology. These are the questions. Am I a covered entity? Again, the answer is yes. Am I transmitting public health information? If it's any communication about patients between clients, if it's any medical information, the answer is yes. And I'm going to say, please, please err on the side of being conservative. If it any way relates to any care of any individual, the answer is yes, that is public health information. The third question is essential, and when I talk about companies making changes, they learned how to encrypt the information that they're sending. And so what happened is there was this cluster of people, this kind of niche of people that were doing encrypted technology in 2020 when the pandemic started, and everybody else had to say, whoa, hold on. These little guys are going to take all this business if we don't get the technology to encrypt the communication. And so that's what happened. And so, you know, good or bad, what happened is 4, 5, 6 really big providers got HIPAA compliant, learned to encrypt the technology, and most of us, through most of the pandemic, have used, I'm not going to name any names, we can think of the most common things we use to communicate professionally. Those are the companies that got there. This last reminder is about the legal implications. Do we have a business associate agreement? Do we have a relationship with that technology provider that we can document and say, yes, the business associate agreement is in place, and with an entity that is providing encrypted services. Bill, have we got any questions, or are there any comments?
Well, the one comment that I had, our compliance division has talked about some concerns with personal phones, that's sitting, right here in front of me, and these voice-activated apps or try not to use some of the words that the companies out there, but
the answer is be careful. The answer is no. These are not encrypted.
Yeah.
The fact, most of what goes on our personal cell phone is not encrypted, and certainly if you talk about any voice-activated device, mechanisms, hot spots in your home, the little thing, we ask a certain woman to order us something. I will not say her name. Mademoiselle, please send me X, Y. They're not, the information is not encrypted. So for the most part, as far as I know, things that are voice activated, most things that transmit over our personal phone. So back to that question, it's so easy, you shoot your kids a text, I'm coming home, do you want chicken fingers or should I pick up mac and cheese? It's easy, right? It is not HIPAA compliant, it's not encrypted information. Obviously, if you're just asking do they want chicken fingers or not, it's not public health information. But for us, I just think staying away from your work, from your personal phone for all professional communication is the safest. And voice-activated technology doesn't have the technology, as far as I know, it doesn't have the technology to be encrypted, and you're going to run into potential HIPAA violation. And it's a drag. It's so convenient, but again, the importance of patient confidentiality, the importance to all of us of doing the right thing. So that's where we've been, and the last year. I know for people in this building, it hadn't even been that long, but I just want to name this whole issue of. So I think about the last 28 months. Word going out: we're going back to work. Should we go back to work? When are we going to go back to work? I want to turn to people in the audience here. Again, folks who've been teleworking or kind of teleworking, coming back, not coming back. What issues are being raised as people move from a partly virtual to whatever to the, I can say it because he's in every newspaper in the world, to the Elon Musk model of you going to sit in that chair 40 hours a week or you're going to be fired. That's what he said, bro. He said, if you want to work for me, if you're going to work for Tesla, you're going to sit in that chair 40 hours. The most versus a lot of people still not home, still working in their basement in their sweatpants. What do you hear as people debate, should I go back to work or I'm being forced? What do people want? What do employers want? What issues have arisen as people are wrestling with returning to work or doing less telework? Anything?
You know, as somebody that hires and is looking and helping others that are trying to hire staff, there's a lot of competition.
Yeah.
And so, you know, at Public Health, we need you here to see patients, and the comments we're getting from others that we're interviewing are that I can work from home and make more money, or I can, you know, and so there's a lot more competition for workers.
Yeah, yeah, and I think, Bill, if you poll people and they're honest, my sense of people is people don't want to do much more than a hybrid part-time in an office. That a majority of people don't want to sit 40 hours. And again, obviously we've got job roles where people have to, where what we need is somebody in the office. But if we ask people their preferences, a lot of people are saying, I don't want 40 hours. I think that's what you're running up against. Yeah, in a job environment where there's certainly for nurses, there's 6 jobs for every opening we got. They got 6 options somewhere else. It'd be a tough time to hire nurses, but even social work, right? What else do you hear as people debate? Do I go to work, and how much am I in the office? And
there are a lot of parents that have the issue of, you know, they've been at home, they've been working from home, so they were able to keep an eye on their kids.
Yeah, yeah.
And now that they have to go back into the office, it's kind of making it tough to find a caregiver.
Yeah, you bet.
Yeah.
A lot of daycare people said we're out, right? Whenever.
Daycares are closed.
You bet. Well, where was the work in April 2020 for daycare? You were watching empty desks, and so you said, I better do something. So yeah, parents going back to work means who's going to watch the kids after 3 o'clock, and the ease of mixing and the stress. I just want to keep it real. I think about my girlfriend who was single mom doing her full-time job and teaching 2nd grade for a year. I mean, that was no picnic for anybody. But yeah, so I'm going back, and what about childcare mother? What about, not so much in rural areas, but what about my commute time, adding that to my life? And the other thing you get in larger cities, I think about Atlanta, where I lived for 30 years. You just added 2 hours to my day. Depending on where you live, you just added 2 hours to my day every day by saying you coming back to work.
And most people feel who've done telework that they are more productive at home because you have the office interruptions that you don't have at home.
Right. That absolutely. People say. So there's 2 sides to that, Kim. I'm going to take both sides. One says, you know what? All I do is put on my baseball hat and fire up the computer. I don't have to drive. I don't have to put on anything. I don't put on a brassiere. Yes, I did. I'm going to keep it real. I didn't have to put on a brassiere. I just fired up my computer and whatever. They got their 8 hours, whatever else. The other side, the people, the Elon Musk model, I need to see them there to make sure they're working. And I believe that people who are going to waste time are going to waste it whether they're sitting in your office. Am I lying? If she's going to be on Facebook and Pinterest, she's going to do it at home or whatever else, to me. But there's this tension of I need them there. So yeah, issues of child care. I'm going to add, what about issues of safety? You know, we haven't been there, especially if I've had the luxury of being home some or all. Now I'm in a position where what do my clients want to know about me? You know, I mean, if I'll take a stand. It may generate some controversy, but it's a good thing to be a consultant. You can fire me. I don't want no health care worker who's not vaccinated in an exam room with me. There, I said it. If you're going to come in and provide direct care to me and you're in my exam room, I want you to be vaccinated. That's my bias. I believe in the science of vaccination. I don't want to get COVID, and I just think healthcare workers who have the option. So, and a lot of employers can't ask, don't ask, make room for exemptions. So what about me as a patient? How are we going to keep other employees safe while we're doing this? And just looking around at various workplaces, you got a lot of health departments. I don't want to be critical, but there's a lot of health departments where people awful cozy with one, and that's a nice way to say it, ain't it, Bill? Where we just don't have the luxury of suites of private offices, and people doubled up on card tables and folding chairs, and poor DIS working whatever broom closet we can put a DIS in. And so yeah, how we won't keep everybody safe being in that kind of proximity? And what, again, back to being the administrator, who's going to sue me? What I do not want, as somebody running the health department, as a supervisor, I do not want nobody to fire me, and I don't want anybody to sue me. And the other thing, Kim hit on it earlier, we talked about families and whatever else. How can I foster team? Both sets of ethics said we're fostering team or relationship with colleagues in a place where these people get their news here, these people get their health information here, these people believe this, and these people believe that. And I'm going to keep it real. It's harder to find middle ground around the politics. And if I believe that masks are keeping me from getting what is for some people still a potentially fatal or very serious ailment, and you say it's not real or you're not going to take prevention, it has the potential to create real divide and I am glad I'm not managing a diverse team of people today, because that issue is really tough, because I do think that in a functional organization everyone's working towards cohesion. Here's what your Attorney General says. There's your answer. Y'all can read for yourself. Alabama Department of Health position. This is the Attorney General position, right?
It is, yeah.
Here's your Act, 2021-493. You cannot issue or require sharing. You cannot require people to share their immunization records. So it's no coming in with your vaccine card anywhere, if according to this act. You cannot require vaccination as a condition of receiving services or for entry into the building. So in other words, we are opening our doors at ADPH to anybody regardless of vaccine status. Institutions of education cannot require students to prove COVID vaccine status as a condition of attendance. So you're a principal, you're a school teacher, you are prohibited. And then businesses cannot refuse to provide services or administration based on someone's immunization status or lack of immunization documentation. What's really important in that act is the provision of supporting individuals' religious freedom. That what they reiterate in the act is that Alabama is a place where people's right to make decisions about vaccine immunization based on their religious beliefs is something that the act upholds. So there's your answer to the question. Can I mandate an employee? Can I mandate my patient? You can't mandate nothing. And so I guess just think about, from a client perspective, your reaction. As a patient perspective, I already gave you my perspective, which is I'm in the health department, and I wish there was a guarantee that that person coming in my exam room about to be intimate with me, maybe in a body orifice. I'm looking at my family planning person. You're gonna have to, if you're gonna do family planning, you may be in an orifice or two. But that person we're vaccinated, that's not an option as a patient at ADPH, right? Employee perspectives, issues for employees. What are your thoughts? Kind of conflict we talked about earlier, them versus us, they're right, I'm wrong kind of stuff.
I think it's best to not have that conversation if you don't have to.
Okay.
It's kind of like in the South where you say you don't talk about sports, you don't talk about religion. So now we add, let's not talk about
vaccine status.
Vaccines. So that's my...
We're doing a don't ask, don't tell. Don't ask, don't tell.
Unless it's absolutely necessary,
Yeah.
because that can cause conflicts in a work environment, and it's just better not to discuss it if it's going to cause issues.
Okay.
I think.
Okay. Got it. No, I think that's where we line up. I've had a number of recent training requests. I've been in my basement in my sweatpants with my dog for 2 years, and I'm just kind of impressed that I'm in dress shoes and dress pants, and I think I did okay. I mean, I was like, well, I do own some dress shoes, other than flip flops, and I say, well, tell me about your COVID protocol, and it's we don't ask, we don't tell, we're not requiring. That's most of the states that I'm traveling to are. And again, I get it. I think to keep the peace and to play devil's advocate, I know some people are caring for their elderly parents. And I'm here at work with you, and we're sharing a card table, doing this work, whatever else, and you're choosing to not mask, and I'm not really sure, but I got to go home and take care of mama or daddy or both.
I think that people in that particular situation or other situations take as many precautions as they can personally. So if you're in that situation, you wear your mask, you sanitize, you wash your hands, you use a paper towel to open the door.
So I'm taking care of myself.
You take care of yourself.
Okay. Yeah.
So that's the best way to look at that.
I get it.
Yeah.
I get it.
But I think that also plays into the frustration of if you have the capability to work from home with your job, but your agency doesn't allow you to, so then you're coming to work with people who may be very vocal about
I don't believe in
anti-vax
it.
status,
I'm not.
and
Vaccines are terrible.
And then you're going home to take care of your new infant or your elderly grandparents or whatever.
Yeah,
And
absolutely.
so that just fosters resentment, unsatisfaction. Lots of things can play.
Anxiety.
Absolutely. Anxiety.
Absolutely.
Unvaccinated kids.
Yeah.
I live across from 7-year-old twins. They have been terrified till they could get them twins vaccinated. And who wouldn't? What parent wasn't? Well, okay. Most parents who believe in vaccine, I believe in vaccine, were terrified for the health of their unvaccinated kids. And so, employer perspectives, I think we've danced around that. How do I, the bottom line as an employer is you better do what the darn Attorney General tells you. That's easy. That's easy enough, I think. But then how do I manage what's going on here in the workplace? How do I promote cohesion, teamwork with the diversity of opinions? Bill, what do you think?
Yes, it's been a challenge. A lot of different perspectives, a lot of different opinions, and then as an employer trying to keep people safe, but also do our job and serve the public. Ultimately, if you go back to our code, it's about the patients and providing care.
Client services, exactly. So this was, I was looking at what do I do from an HR perspective as I was getting ready to do this, and all the issues we've talked about in the workplace. This resource was really interesting. It was like, from a human resource perspective, this is Society of Human Resource Managers, SHRM.org is the website. And like I said, I was just surfing around looking for guidance from an HR perspective about how to manage all this in 20, and what they say first and foremost from an HR perspective, open communication among everybody on the team. Hey, here's what we're doing, here's why we're doing it. Consistency and flexibility. It was really interesting. They talked about, to create standards and enforce those, but that we, if we're doing our job well from an HR perspective, we do understand the role of flexibility. I'm thinking of caring for somebody who's immune compromised or whatever else, and that we do that. Thinking health and safety first, and where you can, saying how do I keep my workforce as healthy and as safe as they can? How do I help them keep how do we keep patients healthy and safe as we do this? And then I think for everybody, I reckon there is room to make sure, beyond what the Attorney General put forward, there's room to make sure, what do our policy and procedures say? And I would make a guess that there are programs within ADPH that haven't been updated to include these hard discussions. And I think, the first thing I'm going to do if I'm going to grieve, I'm going to say, show me where it is in the book, Bill. And if you're a manager, if you're in a leadership role within ADPH, obviously the guidance of the Attorney General is critical. But again, I just go back from an HR perspective. Is it documented in your policy and procedure, and has everybody signed off on that amendment? Is an HR condition to consider as we talk about implications.
And what I'd add to that is, it's ever changing.
Yeah.
The policies and the information that CDC has put out, all of that continues to change. It's sometimes confusing.
Yeah. Yeah.
And so trying to write policies and procedures.
Absolutely.
I talk to our HR director on occasions, and it's trying to keep up with what's the latest information.
Yeah.
And keep a policy. Something hits tonight, and tomorrow morning it's in play from the CDC, and trying to keep your policies up to date with that has been a challenge.
Yeah, I have a family member who's down with COVID, and they're talking about deciding when they're going to come out of quarantine or not, and we're all scratching our head to look for the guidance of how long to quarantine, and when symptoms developed, and when we get a negative test. And you better have a PhD in epidemiology to write the HR manual these days, because it is tricky. And again, back to that issue of workplace safety, back to the issue of patient safety. That's an example. If you got providers coming back to work too early, I'm really concerned about somebody active COVID in the office, and are not making sure our policy is using good science to make sure that person is isolated from their coworkers, from the patients, until we know they're not transmissible. Where have we been? This is kind of a flashback, isn't it? So I just want to go back to the idea of the NASW update and saying, remember to care for yourself and the importance of self-care. By way of doing that, I guess that I sort of feel like we've had a bit of a flashback. Again, there's the language there. Promote policies and materials to support self-care. Paramount for competent and ethical social work practice. It's another quote from the guidance. Challenging workplace environments and exposure to trauma. I was really struck that they called out how much trauma we as social workers, and I feel really comfortable expanding this and saying how much historical trauma anybody working in public health faces. That are the importance of self-care to all of us in public health is, I think, why it was helpful. So this is the earliest data I had. This is 2020 June. This was a household survey. CDC did a household survey early in the pandemic. I just want to talk about the psychosocial stress we've been under, and recognize that going back, I think it's June or July, MMWR July 2020, they did a phone survey. I think it's 4,000 people. Hey, how are things going? I think of July, we were all locked in our house, most of it. 30%, 31% reported anxiety and or depression. 26 reported trauma symptoms. 13% increase or use of substances. 11% of 4,000 people in this phone survey had seriously considered suicide. Again, 4,000 random Americans. Hey, how you doing in the early days of COVID? That last one is astounding to me. What you'll see as we move forward is the other figures have remained remarkably consistent as we progress. This was again, what seems so fun. In some ways, March 2020 seems like it was 10 years ago. What you may not remember is the census was going on at that time. And so at some point, somebody said, hey, we got all these people out there going door to door. Let's add screening questions in the mix. And what they found was in response to, I think, the census, people just added a depression screener and one anxiety screener. So it wasn't like they were training, but they added questions, 30% positive for anxiety screening. Again, go back to that CDC statistic, about a third of people were having symptoms of anxiety, depression. Worse outcomes for young adults, females, poor educational attainment, lower educational attainment, and Hispanic, non-Hispanic, other multiple races. And I would highlight that young adult thing because what's borne out, and I've got more impact, psychosocial impact stuff, but that younger age group has always shown higher symptoms of distress, mental health problems. And what I don't have, and what I cannot find, is anything quantified that says if we keep going back to teenagers and children, we're going to see that continued trend. But if what you look at in this study, most studies I see, heightened psychosocial stressor for people in their 70s or 80s. Obviously, you think about early COVID, that was our biggest concern, sort of dropping off across age groups, and always an increase among young adults. And I sort of suspect, given that trend, and again, I can't find hard data, what's the impact been on adolescents and kids? I suspect it's a lot worse than we know. Bill, do you have a question? Did something come in, a comment? No worries. No worries. I saw that action. I just want to make sure I wasn't missing something. So fast forward. This is This is a meta-analysis article. Just sort of looking at, I want to say it's 60 or 70 studies on the psychosocial impact. It's still early, but again, look at the figures always. And again, this has been consistent. All the looks that I've done, anxiety is the most common symptom. And there's the range he's got. Most people say it ends up, if you average everything, about a third of people reporting more anxiety symptoms. Just under that, nearly a third, but usually a little less, reporting symptoms of depression, distress. And look at the figures on PTSD, 7 to 53%. And again, so that's a range. I would have to argue that the actual rate of PTSD is probably much less. This is an early NIDA article, National Institute of Drug Abuse, the impact of COVID on substance use. And this I think is concerning. What they said, this is the director of NIDA, said what we are seeing is a combination of stress, plus social isolation, plus the economic distress. Remember, people who were, losing work. I mean, you think about April, May, June of 2020, people were, I remember one guy in my neighborhood sitting there smoking a cigarette. I said, "How you doing?" He said, "Well, I'm okay. I lost my job at the sushi restaurant up the street, but I got a little savings, so I think I'll be fine." And I've thought about that dude a lot, just sitting on a step thinking, 6 or 8 weeks off, I'll smoke some pot and, and have a couple months to go back to work. And I thought, brother, you didn't. I don't know where he went. He ain't still on that step, but I just think, hopefully he got some expanded unemployment, maybe. But the economic distress was real and sustained. So increased frequency and amount of substance use is what she reported. There's your figure on alcohol sales. And we kind of joked about it. I know there were a lot of jokes about mommy's having a bigger glass of wine here in COVID or whatever else, but 54% increase March to March. That's not just one more glass of wine. I think a good deal of that is problematic use. Knowing what I know, a good deal of that is self-medicating around the anxiety and depression that I talked about. And I would argue that embedded in that is people whose use progressed from normal range drinking to problematic substance use. And I would also argue, and I cannot find hard data, I would also argue that a part of that is a bunch of people who were in recovery who relapsed as part of the pandemic. And again, I can't find any hard data. I know people in 12-step recovery who say, oh yeah, we see a lot of people coming back after a relapse. I can't find anything that quantifies how much that happened. In 2020, we saw an increase in overdose deaths among opiates, other overdoses, particularly methamphetamine, that much higher. 40 states in 2020 had higher year-to-year opiate overdose rates. So that's what happened in the general population. What about healthcare workers? This was another. Gosh, this was, I think this is a 2021, anyway, it looked at, 37 studies. Most of these were non-U.S. studies, but it looked at sort of what's happened to healthcare workers. And Bill, to your point, sort of here's what's happened. This is a mix of mostly frontline nurses, social work, PAs, but people in, a lot of this is people in inpatient medical settings. So that's the bias there. But again, look at the anxiety, look at the the prevalence of PTSD? 20%. And that means diagnosable symptoms of PTSD more than 6 months after. Look at insomnia, look at alcohol misuse. And again, this is not one isolated study. This is a meta-analysis of 37 different studies that looked at what's the psychosocial impact been. And Bill, when you said, sort of people who went here or there to deliver care, my stepson was very ill in not a big city, but in Virginia, in Roanoke, Virginia. And he was in ICU critical care for nearly 4 weeks. And I'm telling you, there was it was in between COVID waves, so people were not dealing with a lot of active COVID. But I say you could almost feel in the air that what those nurses, what those frontline staff, respiratory therapists, everybody cleaning rooms, what they had been through. And you sort of talk about being an ICU healthcare provider and for folks who've done it for 2 years, you can't tell me that it's at least 20% that don't report some trauma history, some symptoms of trauma.
I talked about it earlier, and the people I've been talking to are talking about nurses that went off, and basically they worked for 2 or 3 months and have come back as travel nurses.
Yeah.
And they didn't have benefits.
Yeah.
Their benefits, it was really cash. It was a lot of cash, a lot of money. People were able to pay off student loans and all kinds of other
big money.
things. But now they've returned to, maybe a job they used to have, or a hospital, a local hospital, and so they're struggling with these different.
They brought all this back with them.
They brought it back, and how do you deal with it, and who's responsible for helping them? Take care of that from a financial standpoint.
Yeah, absolutely. And again, as part of hiring, as part of nursing support, how do you support a workforce? Not just hire, but how do you support a workforce that's had this kind of injury? Frontline staff, again, in the study that I'm referencing, frontline staff, women, younger staff, and nurses had poorer outcomes. That is, worse behavioral health symptoms, except for alcohol use. That seemed to be equal across professions, across whatever else. And higher exposure to moral injury resulted in more behavioral health. And I don't know if the next slide is there, but moral injury is like something that goes in opposition to your values, like not being able to give people PPE who needed it and couldn't, like not being able to let people say goodbye to their grandmother, things that went against what you felt was morally right, but that you had to do, given. And those people who had moral injury had higher levels of mental health symptoms, again, depression, PTSD. Name the emotions you've seen here in the room. Sort of which of those emotions do you see with your family, with your friends? If you were to take a highlighter to what I've talked about, what do you see in your workplace? What emotions seemed common as you looked at those slides?
Just among family, especially with family that are older and have health issues, fear, the biggest things, like what will happen to me if I contract the disease. So you have an overabundance of caution because of that fear, and so you have the isolation.
Fear, isolation. The other thing about the stress we've been under is there's a lot of stuff that says a stress response is meant to be short-term. Like back when we were cavemen, there's a dinosaur at my thing, your physiology revs up, you have this fight or flight, you have this physiological reaction, and then the dinosaur leaves your cave and it's over, it passes. Some of us, we've been under alert for a long time, and so as I try to make sense of this, what are our models of being under that level of stress? And for other people say it wasn't a big deal. There's a whole range from highly stressed for the last 28 months to not stressed at all, and sort of where people are at along that continuum.
Depression would be what stands out to me, especially in the nursing field. I mean, it seems like there's such a shortage of nurses now that you have clinics and hospitals that are assigning nurses all this extra work, and they're overloaded, overwhelmed. They're having to take care of patients at maybe unsafe ratios.
Yeah, that's what I was going to say.
That's a threat to their nursing license, and if they lose their job, hospitals aren't they're not going to back that up. So it's a small picture, but it's also such a bigger picture when you start talking about cause and effects for these types of things.
Absolutely, absolutely. Where nurses have been, but yeah, absolutely. A bunch of nurses said, "I'm done."
Yeah. I was going to piggyback on that to say a lot of nurses have left bedside.
Yeah, you bet.
They are done.
You bet.
Yeah.
You bet. If they had the luxury, they're done. Or if they can do telehealth or work for an insurance company, just talk to people. Or exactly, they said, "I'm done." And again, that issue of, I got my RN license on the line. I'm counting on these visiting CNAs to keep my 15 patients alive, and I hope nothing falls through the cracks. It's a pretty stressful life, and COVID and everything else. And yeah, I mean, I think the only thing I would add, and I just would echo what Kim said, is this stress of the response. That I was visiting family last summer, and my cousin's wife had kind of a meltdown at dinner, just talking about how exhausted she was as a nurse, how exhausted her peers were, and that hearing people who were opposed to vaccination, who were opposed to masking, when she believed in the science behind those tools, then being admitted for care, and she went off. I mean, it was... and I can't argue, but that if I'd been on the front line, cared about other nurses and people who had mocked vaccine and masks, getting sick and then coming in and being that third wave. I mean, there's no way you can argue that that third wave was unvaccinated. I don't know if we're on the third wave or fourth wave, but there was a huge wave of people who were not vaccinated. So there's a reminder to our folks outside. Just, to kind of, now I'm really stumbling here because I don't have the answer. Kelly, you sat here for an hour and a half. I don't have the answer, as always. But I raised this question of, has COVID been a collective trauma? Bill, as you talked about people going to New York City, whatever else, I think about our models of trauma, and I even think about our models of natural disasters. And I think, what, this is not one hurricane that happened in one night and the post whatever else. This is something else. But I just think, I put out the question, what if this has been a collective trauma? What if it's affected an entire society? What if we keep recalling what's happened as an attempt to make sense of what's happened? I have COVID dreams, right, where I don't think I spend a lot of conscious time, but getting it and being afraid of it, and it is in my subconscious, and it comes up all the time, an emotion about it. So what we know about natural disasters, this guy studied natural disasters. Again, this has not been a tornado, whatever else, but for people who are directly exposed, prevalence of PTSD is about 20 to 30%, a higher impact of PTSD for kids. That's why, again, that the studies I see about younger adults faring worse on mental health symptoms concerns me, and it leaves me wondering what's going on with kids. But in addition to PTSD, higher depression, higher anxiety, although substance use not significant. And PTSD appears to resolve except in about 5%. So what about this? I'm just going to end with some questions here. What if COVID has been a sort of natural disaster, and what is the lasting impact? I'll give you mine. I was joking about this yesterday. I did training down in Mobile. I can't have strangers in my physical space. If I don't know you and you're too close to me at the grocery store, it gives me the willies. And I'm not ready to go to no movie theater and have people I don't know coughing on me. People talking about, oh, don't you want to go to a concert? I'm like, and be next to strangers? I have a physical space thing. I don't know when I'll get over it, but I can't have people I don't know. If I'm in a busy, I've never been great about it. If I'm in a busy place, I'll throw my groceries down and get out. I can't have people in my space. Again, I think that's just having spent 2.5 years being afraid if people got closer than 6 feet. I've got some lasting trauma. So as we sort of think about where we go professionally with our patients, there's some really interesting, compelling work as we look at the trauma literature there's people who say, who survives trauma? You saw that figure earlier. 20-30% have PTSD. 5 to 10% have lasting PTSD. It resolves over time. These are factors related to who survives trauma. It's called the resiliency literature. Really interesting stuff. There's a husband and wife team at Duke. Oh, I hope I come up with their name. I came up with their university. Connor Davidson. He came up with Connor Davidson resiliency scale, and what they say is people who are more likely to survive a traumatic event have social support, have an action-oriented coping style. That is, they're taking action rather than being passive and just waiting for things to happen. Sense of self-efficacy, sense of purpose. They talk about what happened, what they've been through, and they seek help. So obviously these things relate to sort of natural disasters or traumatic childhood events, adverse childhood events. But again, I'm just playing here with, if we've been through a collective trauma, which of these factors can we promote as managers, as leaders? Which of these should we look for? And I think for those of us who need to get on board with the self-care thing, which of those things we can do? I think what's important as we sort of look at who needs what level of help, I would argue that people that were depressed before are more likely to have depression. So what was going on before? How severe is their current distress? How high is the current stress? And what coping skills have they dealt with in the past? So let me do that last slide. If there are questions or comments, it's your last chance. Folks here in the room, anything you want to add or ask?
I think part of that resiliency that you just touched on, I would argue that made this particular trauma with COVID even more difficult to be resilient, and that action-oriented coping style.
Yeah.
You know, how can you take action when everything's shut down? You can't go get groceries. You can't go to the park with your kids. You can't go get a haircut. You know, you can't do any action when the world has shut down. So
and we were powerless. We
So
were powerless to do anything about it, waiting for this thing to happen. Absolutely. I mean, what I did is, friend, I alphabetized my spice rack. My pantry has never been so organized as those first few weeks. Girl, I'm telling you what, the soup cans were lined up. But yeah, where things were outside of our control. Absolutely.
Yeah, it's presented a lot of unique challenges that we haven't been able to have that resiliency with other disasters.
Absolutely. And again, the idea that if a tornado took your house, you're out there in your neighborhood, you're picking up lumber and you're doing something about it. The safety isolation, the emotional isolation, that for a lot of folks, and I think the point is there's still a lot of folks for whom isolation continues to impact their self-care, and a lot of people that we don't even know about for whom isolation. That was a really insightful comment. I do think there are a lot of people for whom the isolation has caused lasting harm. Do we have questions?
We have a comment that came in, and this is back to the HR strategy.
Okay.
And I think actually it could probably be used maybe in several different places, but it talks about transparency and just being transparent when you're making policies and putting information out to your staff about why you're doing whatever you're doing.
Absolutely. I think that was implied. The first bullet was communication, but that's exactly right. Here's why we're doing what we're doing. I think what's really important, if you're out in a county, here's what they're telling us from Montgomery. You know what? If you're out in the county, blame the folks here in the big house. That's why they're making all these big bucks up here in the big house. But yeah, so here's what policy, here's what Alabama law says, and here's why we're doing this. To name the elephant in the room.
And one last comment. As we've talked about COVID, we've talked about specifically the disease and the processes and things like that we've gone through, but the economic issues that have multiplied over the last 2 years, shortages of staff, shortages of transportation, shortages of toilet paper, medical supplies. All of these things have created additional anxiety on top of the anxiety of, can I get sick and die? We had a letter from a mother who is very frustrated that her child who needs trach cannot get access to some of the medical equipment, and that's because there's been supply chain issues, and that's magnified and made this this disaster, this emergency natural disaster, even worse. And then on top of all the social issues, and then a war across on the other side of the globe, and just all of that has compounded
a very unprecedented, stressful time.
Yes.
Yeah. And Bill, I'm going to end as I often do when I teach about self-care, with a serenity prayer, because ultimately, to me, it's about what things do I have control over, what things do I not have control over, and the wisdom to know the difference. And I can't fix the global supply chain. I can try to get along with the people here in my office. I can try to provide good ethical service to my clients. Anyway, I want to thank everybody here. Bill, thank you for setting this all up. Thanks to you guys for making time. Thanks to people who watched on the video. It's been a great conversation, and I think, Bill, you're going to close us out.
I am. You know, the good news is, Jim, tomorrow we're going to come back for part 2.
The other part, yeah.
So, yes, this concludes our program for today, but Jim will be back tomorrow for part 2 of this program, and we hope you'll join us.